requiring a second go-around. Opportunities for second go-around are, are dialysis or transplantation or conservative care. Transplant patients with failed transplants do very poorly on dialysis. I don't think that we're adequately using repeat transplantation in the best possible way that we could. And as always, I'm going to then hammer for the idea of preemptive living donor transplant. So now I can sit down and entertain questions. But I'll just give you this. I'll give you like a bit of an overview of some of the things I think are some nuances. So these were my objectives. So the epidemiology, basically, it's actually now the fourth. People say fourth, fifth. It's the fourth leading cause of ESRD is actually patients now who have had a transplant and are failing and coming back. And that's no surprise because we've been doing transplants for a long time. And even if our results are excellent, there's going to be increasing numbers of patients who are getting to the end of the life of those kidneys and that are going to be looking to have ongoing therapy. So this is US, similar in Canada. Canadian results are better than US. BC results are, as good or not, if not better than Canadian results in general. But you can see results are improving. But here in the US, at 10 years for a deceased donor transplant, more than half of them have failed by 10 years. And some of them have failed because the patients have died, but some of them have failed because the grafts have pooped out. And as always said, now probably chronic antibody-mediated rejection is the leading driver of this. And so these are patients who are alive with a failed kidney. So these are this is the burden of patients now coming back for a second go around for treatment. Similarly, improving results with living donor, but significant number of patients by 10 years, even ending back up requiring the second go around. And this is the death censored one again, not 20%, but still 20% of a sizable number. So a lot of patients, requiring retransplantation or redialysis. So allograft half-lives are improving, but they're not good enough to prevent this bolus of patients. And, in terms of this is now up to 5% of patients in the US starting dialysis. And I said it's the fourth leading cause of patients starting dialysis. So it's significant. And Owen showed you this slide. So patients after graft loss do poorly. And so when you look at patients after graft loss who have comorbidities, which is significant, they do even worse and worse and worse. So peripheral vascular disease and diabetics. So diabetics failing, going back on dialysis, probably no surprise how badly they do because they do very badly when they go on dialysis the first time. And we all know that there's a huge survival advantage to transplantation over dialysis for diabetics. And Owen showed this slide, but in particular, especially in the older patients, they have a very high mortality when they go back to dialysis. So, and another, just hammering it away, this is another study showing a threefold higher risk of death. So dialysis patients who after failure, bad outcomes, and showing you again what Habib said, second leading causes the infectious complications, the leading causes the cardiovascular complications. So a high burden of cardiovascular disease, a high burden of, because of the immune system impairment, because of long-term immunosuppression, maybe numerous attempts to salvage the graft with intensifying immunosuppression, lots of infectious complications as well. So management after allograft failure as opposed to while it's failing. So briefly glossed it over all when saying no one has looked at this transplant nephrectomy, and then the question which haunts me is what do we do with immunosuppression when the graft fails? So as far as nephrectomy goes, we're not really enthusiastic about nephrectomy. In the first year after transplant, when the transplant fails rapidly, probably to acute accelerated rejection, the transplant, there's a lot of complications. You want to get patients off of immunosuppression quickly, then you're probably stuck with doing the nephrectomy. But after the first year, it's much less likely that you would want to do a nephrectomy. And so Really, the indications for nephrectomy after, when it's late, when the kidney sort of pooped out, is only when the patient develops symptoms of rejection. And usually that could either be pain in the graft, a hematuria, or sometimes it's fever. Sometimes it's just fever, feeling lousy. You look for other causes, and eventually you settle on the graft and you end up taking it out. Most of them we leave in, and this is just what goes on around the world is that early after transplant, within the first year, more are taken out than later on. So, we've had whole talks on this. We've had lots of debates on this. What do we do when with the immunosuppression when the transplant fails? And obviously, there's three options. One, you just stop it. Two, you wean it off gradually, and three, you leave patients on immunosuppression. And the reason that I don't have a good answer is nobody really knows. There is no good study. There's evidence on both sides of it. I've picked two papers. One is, the title is It Should Be Stopped, and that's because there's a lot of infectious complications on patients who are on immunosuppression after a failed transplant versus patients who are off immunosuppression. And so that obviously stands to reason. On immunosuppression, on dialysis, the immune response isn't that great on dialysis anyway. That combination is particularly bad, and you're going to see infective complications. The flip side is sensitization. So if patients are looking at a second transplant and they're going to go on the deceased list or looking for a living donor, the more anti-HLA antibodies which they develop, the less likely it will be that they'll be able to find a compatible donor, and then the longer they're going to have to wait. And obviously, we're greatly disadvantaging our patients by sensitizing them to HLA. Does keeping patients on immunosuppression eliminate that? No. How much does it reduce that? Unknown. Right now, we continue to struggle really because there's no good studies to really tell us what we do. So a practical, and I come down to being practical, is that if the patient is not a candidate for a second transplant, then withdraw immunosuppression because you don't need to worry about sensitization. If the patient is a candidate, then you got to weigh the pros and cons. The degree of sensitization already. If they're already very highly sensitized, that means they're going to wait a really long time. They're going to be keeping them on immunosuppression for a really long time. They're already sensitized. Maybe it makes more sense to stop it, although you may then allow them to be sensitized to the one last donor that they could get. On the other hand, if somebody's going to get a transplant early or they have a donor lined up, then it absolutely makes no sense to stop immunosuppression because maybe you will sensitize the patient against that particular donor. So pros and cons, I think the longer you're going to have to wait, the harder it is to justify being on all that immunosuppression with the only benefit being you're preventing sensitization versus reducing the risk of infection. So what I want to talk about is repeat transplantation and talk about, I think, patients coming around to a transplant failure and then options are disadvantaged. So only about 12 to 15% of the wait list, and maybe more with kids, but not that much of the wait list is made up of second transplant patients. And so overall, this is work that we did at St. Paul. John and Owen and our Vancouver group, our Vancouver ClinEpi group did this. They looked at U.S. data, and overall on the transplant waiting list, about 25% of ESRD patients are listed for a first go around on the transplant waiting list, versus only 15% of patients who have had a failed transplant now looking at a second transplant. So, just raw numbers, 15% versus 25%, is that justified? So big population of incident dialysis patients and transplant failure patients, 1 million versus 100,000. And then, so there was enough data that the transplant failure patients could be matched with an end-stage renal failure patient. And so these are matched patients. So these are patients who are, this is a multivariate analysis, so looking at a matched group of patients, the transplant failure rate is going to take long, the patient with a transplant failure is going to take a longer time to get onto the waiting list, and less of them are going to get on the waiting list. So for match for all of the other complications, they're disadvantaged. And so the relative risk of you had like a 50% lower chance of getting on the waiting list if you were a retransplant patient, even though you were matched for all of the other characteristics. Now, one of the reasons might be you say, well, they don't do as well. So maybe it's not, this is looking at a graft loss for any cause. And so, yes, there is a disadvantage to some extent of a second transplant. Second transplants don't do as well as first transplants. They particularly don't do well because of rejection. So this is death-centered. So removing death as a cause for failure, there's a lot more immunologic failure in second transplants. In fact, they don't die with a functioning graft. What happens to them is that their transplants fail for other reasons. And that's probably because of their high immune risk. But again, does that really matter? Are we really should we be comparing first transplants to second transplants, or should we be comparing second transplant opportunity to what are the other choices? The other choices are dialysis. And so is it, if you look for that particular patient, what's the best treatment option? And these are these statistics actually. So the risk of dying after a second transplant, right after surgery over here, is actually lower than it is for first transplants, matched for the same comorbidities. If you're a diabetic, you do so badly on dialysis and you do terrible the second time around that your risk of dying with a transplant already is actually lower than it is with staying on dialysis. But I said they don't do as well, and so the prediction of which ones are most likely to fail is the longer that the first one lasted, the more likely it is to be successful. So the relative risk when the first one was lost within the first year was really high, and if you kept your first transplant for a long time, you're almost the same as first time around. So not all second transplants are the same. So the desire to do a second transplant is you do better than with dialysis. The reluctance is you don't do as well as you did the first time. But those who lasted a long time the first time do very well the second time around. And as Olin said, if you're going to do it, you should do it early, because there's a survival advantage to doing it early, and you should do it preemptively, and that means a preemptive living donor transplant. The longer you wait on dialysis, the more risk you have of dying. And the longer you wait on dialysis before you get your transplant, the more likely you are to die early after your transplant. So you can't get back those extra years on dialysis. They're taking their toll on you after your second transplant, just like they're taking their toll on you after your first transplant. And therefore an early transplant and then a preemptive early transplant is definitely the best way to go. So in terms of timing, there's no reason to delay. Getting patients transplanted earlier is better. Preemptive is best. And then obviously, if you're going to do it, living donor transplants still have, I didn't show data for this, but living donor transplant outcomes for second transplants also have the huge survival advantage as they do the first time around over deceased donor transplants. And if you're going to get a preemptive transplant, it's going to be with a living donor. So living donor first. A few nuances that I want to talk to you about. Let me go back one. Nope, not going to go back one. Okay, anyway, so, who's a candidate? Same as first time around. Really no difference, but there are some absolute contraindications, and the absolute contraindications are on my first slide. Cancer, how long do you wait? We individualize. Some cancers a long time. Some cancers you can go right to transplant. Bad liver disease, bad heart disease, liver disease and heart disease. If you can get it combined, then maybe. But if you have decompensated cirrhosis, or if you have very bad congestive heart failure, you're not going to get it combined. Those are rule outs. If your blood vessels are so bad that we can't actually do the surgery because of the calcification, that's a rule out. But there's not that many rule outs other than, complete, fragility, disability, frailty. And so just a couple of little things. People, if the first transplant fails because of BK, polyomavirus, can you do it a second time? You would say, well, got a virus or viral complication, that would have a bad impact the second time. In fact, not so. So this is looking at patients transplanted in the US up to 2010. There were 68 patients who lost their first kidney to BK. There was an interval of time. All of these patients now had a prolonged interval of negative BK viremia testing, came back for a second transplant, mostly got Simulect versus thymoglobulin, so a little bit less immunosuppression, but you can see really good results. Also lymphoma, so you'd say, oh my God, they got lymphoma from immunosuppression. You couldn't possibly do a second transplant because they're going to give them immunosuppression. Second time, selected, but yes, we've done a couple ourselves of patients who have had lymphoma first time around. The best prognosis is in kids who were EBV negative going for their first transplant, and then got lymphoma, but then EBV seroconverted. So now they have some natural immunity to EBV. So would that drive it the second time? Not necessarily. And so long disease-free intervals, changing from negative to positive serology, and if it's confined to the graft, which has undoubtedly been removed, those are all good prognostic signs and reasons why maybe you could retransplant somebody who had PTLD. Big conversation, the non-adherent patient. So they actually lose their graft now. We're talking about how non-adherence is leading to DSA, and DSA is leading to graft failure. Well, what happens if they actually now lost their graft? Are we ourselves a little bit in denial if we then say, okay, sure, let's try it all over again? So clearly, this is a challenge for us, and it's a difficult thing for us to talk about with our patients. I think we do really well with the polyoma in your kidney, and we do really well with your serum creatinine, but look at those tacrolimus levels. They're all over the map, and maybe that means you're not taking your drugs, and let's talk about that. I don't think any of us really do a great job about it. And so now you've lost the transplant second time around. We all really want to help our patients. We know that transplant is better than dialysis, but we have to do something to help them adhere the second time. We have to do something to make a difference. And so now there's a lot of energy, there's a lot of effort on programs and education, and to develop a patient education, a patient support to help with adherence second time around, I think is something mandatory. We don't have all the answers yet, but I just want to put that up there. This is from University of Michigan, who have their own algorithm, but you can see that they use their algorithm and they put on the full court press, but second time around they still had a lot of non-adherence. So it remains a big problem, and it remains a bigger problem than I think any of us would like to think about. So if you can do 2, why not 3? Again, survival advantage for the third transplant is there over being on the wait list, but there is decreased graft survival in the second one versus the third one. But again, the longer the second one lasts and the longer the first one lasts, the longer the third one's going to last. So in selected patients, it's not crazy to do a third transplant. So in summary, transplant failure patients are increasing. They don't do well on dialysis. They have heart problems. They die of infectious diseases. They're still in a survival advantage to a second transplant. Being on the wait list, they don't do that well. So preemptive living donor transplant second time around. More patients probably than the 15% which are in the US. I think we want to proactively look at in our post-transplant clinics, identify patients with failing grafts and target them also for preemptive living donor transplants. So with that, I think I'll stop and we have a few minutes now for questions around you know, the immunologic issues, the CKD issues, and the second transplant issues. Thanks. I know there's lots of people out there in the region, so I'd like to invite somebody from one of the remote sites to ask a question.
Hello, can you hear us?
Yeah.
Hi, it's Melanie. We're in Surrey here.
Hi.
Hi, just a couple of quick questions, hopefully. So, in the setting of biopsy-proven chronic AMR, where there really is no acuity at all, you know, we order the DSAs, but other than preparing for repeat transplant, do they serve any other purpose?
I can answer this too, but sadly, our biggest treatment failure, our biggest treatment challenge is those patients who have chronic antibody-mediated rejection. We have tried just about everything that Olin has put up on her slides, and then things we go to the meetings every year. We hope that maybe there is something there. There's a little bit maybe about that IL-6 antagonist that Owen showed you on one of her slides. Very early, very tentative. It'll probably cost so much in Canada that we'll be challenged to ever get it anyway, but unfortunately not much. No, I guess.
Not really, Melanie. I mean, the biopsy is never clear cut as well. There might be some acute elements in a biopsy that might benefit from a pulse of steroids, etc., that might delay the progression of failure. But at the end of the day, the horse is bolted at that stage, and it's you've gone past return. James will talk later about chronic antibody-mediated rejection, but I don't think he's going to give us any revolutionary thoughts. But it's an area that is a lot of study is going into at the moment, because that's a huge area.
But we're getting good at making the diagnosis now.
Yeah.
Okay, thanks. I have one more, but maybe I'll let other sites go first.
Hi, this is Jocelyn. I just wanted to ask if there's discussions with PRA around getting these people covered for their medications for the CKD aspect of it, or how people are managing that at other sites other than just trying to do it covertly.
Is there anybody from PRA to... I don't want to say anything. I don't want to say anything that I shouldn't, but it's my understanding is that if you register your patient as a CKD patient as well as a transplant patient, which is what we do, then they are covered by PRA. Yeah. Gary's here. That's correct, right?
That is correct.
Yes, that's correct. So there should be no obstacle to, if they are a CKD patient and qualify as CKD patients, that they could be covered, within the PRA formula for their non-transplant related medications.
Right.
But I might have unleashed a torrent here, but I think that's correct.
Yeah. At the end of the year, we get an audit that they're dual registered, and that we have to fix that. So that's just the only piece. If we can ignore that audit, that's lovely. Okay.
Yeah. No. So a lot of our patients are they are on the dual registries, but that's the way it's going to be until they actually fail.
I think that's an important enough question for us to get an official answer, so I will bring that to PRA and give you an official statement. I'm 90% sure what I'm saying is correct, but that there is no barrier. In fact, it's recognized that we can and should do this, but I'll confirm that for you. Other questions?
Melanie, do you want to ask your second question if there's no questions?
Yeah, sure. So my second question was, is there any evidence in the literature that non-adherence pre-transplant, so say to antihypertensives, dialysis, whatever it is, equals non-adherence to post-transplant meds?
Yes, so there are a few studies, and again, it's in that population of adolescents. There's several studies looking at that, and really the solution, we haven't really got a solution. I mean, age is the solution sometimes, but education, several education programs have been tested in those populations. But certainly there is a continuum of non-adherence before, non-adherence after, and as David talked about, for repeat transplant, the non-adherence is an ongoing issue as well.
Yeah, thanks. Sometimes that's something that I struggle with. If they're demonstrating not very good compliance pre-transplant, do you send them for evaluation for transplant if that's the case? And I do, but it's...
Yeah. So we see a lot of these people, and we know from their records of dialysis records as well, there's non-adherence. So they get extra, education and workup from our team as well. Whether that makes an effect or not, we certainly monitor these people more closely after transplant too.
Thanks.
If there's any questions from here?
Okay, everyone, we have a 15-minute break. So thanks, everyone, and we